Today's speaker is Dr. Marie Brown, who is the Director of Practice Redesign at the American Medical Association, a Professor Emeritus at Rush University, and proudly a practicing physician in internal medicine for over 30 years. Today, Dr. Brown will be presenting on medical assistance, recruitment, and retention. Welcome, Dr. Brown. Thank you again for being here with us today. I'm going to go ahead and hand it on over to you.
Great. Thank you, and thank all of you for taking the time out of your extremely busy day. We are recording this in February of 2021, when we are in the midst of a pandemic, the likes of which none of us ever could have imagined. So I know that you are incredibly busy, and your teams are very busy. So I thank you for taking the time and hope that this will be helpful in your day-to-day as we get through this. And hopefully we get through it soon. So as mentioned, I am an internist and have worn several hats and been able to practice in several different types of practices. I began working at an FQHC, a federally qualified health center, where I met many medical assistants. I then started working in a two-person practice where I trained my own medical assistants, and then joined Rush and worked again with medical assistants in a large integrated health system. So I've seen practice from a variety of ways, and the medical assistant has always been a critical member of the team. Today, we're going to talk for about 30 minutes on different pathways to becoming a certified medical assistant, how to make the best use of your medical assistant and everybody on your team. And once you have a great team, how do you keep them engaged, give them professional development and opportunities, and make the work meaningful for every member of the team? I like this quote from Dr. Don Berwick. This work is just so wonderful. And what we all as a team get to do really touches the highest aspirations of a civilization. For many of us, this is a calling, and it should give us great spiritual satisfaction to, at the end of the day, feel like I made a difference. I made somebody's life a little better. And we hope that everybody on the team feels the same way. However, with regulations, with the EHR, with COVID, with so many challenges, sometimes it is less efficient and a little frustrating. In addition, we have quality metrics that we all need to meet. And in the past, quality metrics were often, what's the goal for this patient? Doctor, PA, nurse, did you make the correct recommendation? Did you prescribe the right antihypertensive medicine to get their blood pressure down? That was the past. Things have changed now, and outcomes matter. The present is not did you make the right recommendation, but did the patient achieve their optimal health? Did we successfully get that blood pressure to goal? Did we successfully treat that depression? Did we successfully get that A1C down to goal? And that's much more challenging. But for the first time, really, in the past 2 years, since 2019, outcomes matter and the financial incentives are aligned. So whether you're in an ACO, performance-based group, are filing MIPS and macro with CMS, or you're reporting to different payers, outcomes matter and are related to some financial incentives. So there's good news here that finally the mission is aligned. We're not just putting heads in beds, we're also trying to keep people well and out of the hospital. And if we get those blood pressures down and prevent strokes and heart disease and kidney disease, there will be a financial reward for reaching those goals. And in addition to outcomes mattering, the knowledge explosion over the past decade has just been enormous. The average visit is about 20 minutes in an ambulatory practice like mine in internal medicine, but there's 1,600 guidelines that we're supposed to address in that short period of time. That's virtually impossible to do if you're doing it alone. And we know that if we are going to successfully take care of the patient and have them have a great experience at a lower cost with better outcomes, we also have to take care of our team. Every member of the team needs to do their work as efficiently as possible, without waste, and work very closely as a team. And that medical assistant is a huge part of that team. It is impossible to do it all. Here I am in my office looking at my screen. I feel before working with a good team, I felt like I was the receptionist, the clerk, the pharmacist, the transcriptionist. And what is my patient doing while I'm looking at the computer? Playing on their phone. This is not sustainable. It's not patient-centered, and we're not going to get to the optimal health that that patient needs. So my team is one of, it's a pretty small team at Rush. Dr. Forbes on the right, myself there, second from the right, and two of our 3 MAs along with our receptionist. We did not have the luxury of having a nurse, but the medical assistants were critical to obtaining the outcomes that we were able to achieve. I will share with you how the MAs are an integral part of the team to help achieve those outcomes. I'm going to highlight a module that will be published in a few months on Steps Forward. These are a series of toolkits that offer real-world solutions, hopefully solutions that you can use this afternoon. We cannot do all this work alone. Many of the tasks that we are asked to perform could be performed by other members of the team, freeing the physician up or the clinician to do the differential diagnosis, to build trust with the patient so that we can motivate the patient to take their medicine, receive the vaccination, or whatever is needed to achieve optimal health. And a key, very often underutilized member of the team is the medical assistant. So I'm going to highlight some of the steps to look at how we can recruit more medical assistants and how, once you have a great medical assistant, how we can meet their professional needs and development and how we can retain them. But why focus on medical assistants? Well, there just aren't enough of them. The ideal staffing ratio may be 2 MAs to every 1 physician or clinician. What I often hear around the country is that there aren't enough medical assistants to hire. So let's step back and talk about the definition of a medical assistant. It is a person who, under the direct supervision of a physician, performs a variety of routine administrative and clinical tasks. And these will vary depending on the location of the practice and the state. A big difference is medical assistants are certified, but not licensed. And their scope of work varies from state to state. So keep that in mind, that some of the tasks that I'm going to refer to here may not be permitted by the scope of work in your specific practice. And we have a link on the Steps Forward website to find out the regulations and the scope of work in your individual state. The other things that vary the scope of work and the roles that the medical assistant takes can be related to whether there's a union in your group, your local Medicare contractor, your Blues, and even in-house, your local compliance officer or the Joint Commission may have a different definition of and regulations that a medical assistant can do. So it will vary depending on your practice, your hospital, your organization, as well as your state. Roles may vary. They're usually broken up into 2, administrative duties and clinical duties. Some of you listening in today may look at a list of clinical duties and think to yourself, wow, my MA isn't allowed to do that. So in some states, medical assistants, including in Illinois, the medical assistant provides the vaccination under the order and protocol standing orders of the physician. And in addition to administrative duties like answering phones, scheduling appointments. They often also do CLIA waive tests, and we also look at care gaps, and in my practice, pended orders as well. Couldn't sign orders, couldn't originate the order, but could pend orders according to protocol and standing orders. There are really 5 steps to recruiting and retaining. And the first is really understanding the various pathways, because there are a variety of ways to qualify to sit for a certifying exam. We're going to talk about the role that your MA plays, because it varies, as I mentioned, and you want to recruit to fit the role that your team has designed for that MA. And then you need to make sure that the organization has the resources to pay for that MA. Sometimes you need to make the business case to go from 1 MA per clinician to 2 MAs per clinician. And I'll show you some data to support that. Once you've found the right MA, and the right MA has found you, you want to make sure that they're trained, that they get onboarded in a very clear manner. And then once you have that team and you're working well together, how do you meet their professional development and their needs so that they stay around? Often across the country, I hear, I had a great MA, but then she went on to something else, or a different group recruited her away from me. And it takes time to build trust amongst your team members. So we really want to keep those teams together as best we can. So let's dig down a little bit more into understanding the various pathways. And these are 4 general ones. And again, an MA is certified, not licensed. Now you can work as an MA and not necessarily be certified, depending on your employer, but most large organizations do require some sort of certification, which includes passing an examination. And the requirements to the qualifications to sit for the examinations vary. The MA that I worked most closely with for the past 10 years became certified through the apprenticeship model. I was in a small private practice and I trained her. She had a high school degree, very smart, very caring, and very interested in healthcare. We did on-the-job training, and after 5 years, I attested to her having performed the role successfully of a medical assistant, provided her some tools and books to study for the exam, which she did with flying colors, passed the exam with flying colors, and she became certified. So she didn't have any separate schooling, but worked in that role for at least 5 years, and any physician can attest to that, and then that person qualifies to sit for that exam. There are many men and women out there who probably had performed the role of a medical assistant, but had not sat down to take the exam. They are qualified to do that. A more common way is to graduate from a medical assistant training program. And these can vary across the country from as short as 9 months to as long as 2 years. Military service and work as an instructor in medical assisting can also qualify. I'm not going to go deep into those two for lack of time, but there are resources provided that you can do that. And each certifying exam has a different set of qualifications to sit for that exam. These are the 3 most widely recognized certifications: CMA, an RMA, or a CCMA. And the links are online so that you can learn more about the details there. There are some innovative approaches to certification, because everywhere around the country, we're all seeking to find ways to increase our medical assistant pool because the need is so great. Some innovative programs have engaged local high schools so that some of the courses that they take, heavily science or health focused in junior and senior year, could be applied to the work, the post-high school work. and get credit for that to shorten that 2-year. Malcolm X, pictured here, is a junior college and is one of the city colleges of Chicago and a fantastic center for many of the health sciences, including the medical assistant. I am the medical director of the medical assistant program. The director of the program at Malcolm X City Colleges of Chicago is Christina Zaga, who's also an author of the toolkit, Steps Forward toolkit that we're talking about today. Many hospitals, in order to meet the need to find more medical and train more medical assistants, are also bringing some in-house programming. These can last from 9 to 12 months, providing a clinical experience within that organization. And the hope is that that person trained will then become employed by that hospital. And they'll also see that it's a pretty good fit. Step 2 is, what do you want your MA role to do when you're thinking of hiring? The role of the MA varies widely. Some MAs are tasked with simply escorting the patient from the waiting room into the exam room, taking a few vital signs, leaving them there, and then going to take another patient and room that patient. We call that room and run. So they simply escort the patient in, take some vital signs, and leave. The other end of the spectrum is team-based care, expanded role for the medical assistant, and one which fortunately I had the opportunity to participate in. Here, in between visits, the medical assistant will do pre-visit planning. They can pen orders, they'll meet care gaps, they'll identify whether the person is due for a mammogram, colon cancer screening, vaccinations, and they'll tee that up. All driven by protocol, all driven by standing orders. So there's a wide spectrum. You need to know what you're hiring for, and it may vary across your institution. Some clinics will only want the person the MA to do a room and run. Others will be intermediate, and some will be very much involved in a team-based approach to care, which is more efficient. So we really need to understand the skills of each member and what you expect that team member to do. This, as I mentioned, will vary depending on a variety of factors, including your state law, your local culture, the unions in your organization. And I mentioned those already, but I'll also mention that the practice culture is important here too. Many physicians are used to doing everything themselves, the lone wolf, and they're unaccustomed and a little hesitant to delegate some of these tasks. And we also need to think about the patient population. What are most of the patient's needs in your practice? I'm going to give you several examples. At the University of Colorado Family Medicine Residency Program, they implemented a new model of MAs to physician. And the intern, first year resident in family medicine, had one MA assigned to them. So the ratio was 1-to-1. That MA got to know that intern and did some initial roomed the patient and brought the patient into the room, took the vitals, and began the beginning of a chief complaint and a history of present illness. During the second year of the residency program, the second year resident had 2 MAs assigned to one. And those MAs on that team did pre-visit planning, pre-visit labs, as I've described, and began to provide more support for that resident. By the third year residency in family medicine, the ratio was 2-to-1, 2 medical assistants to 1 physician, similar to what attendings experienced and had. And the difference that year is that the medical assistant provided in-room support. So the MA stayed with that patient from the beginning of their visit throughout their visit, stayed with the patient after the physician went on to the next exam room, went over the patient education, the plans for tasks needed between this visit and next, and then escorted the patient out of the room. Another example is up at Bellin. This is another author, Dr. Jim Jerzak, of the Steps Forward Toolkit with in-room support. The doctor is focused, eye to eye, discussing things with the patient, building trust, making sure that the medication adherence is accurate, because we know that patients often are asked, do you take your medicine? And they routinely say yes, but in fact, they may not be, but they're afraid to say that for fear that they'll get yelled at. So making sure that we understand how many pills they might have missed, or are you having any side effects, or what is preventing you from being able to take that medicine, or why are you declining the vaccine? Tell me what you're concerned about. And all of this conversation builds that trusting relationship while somebody else in the room is documenting what the patient is saying, entering orders, looking up previous lab results, so that the doctor and the patient can talk uninterrupted and really get down to what the patient's needs are and meet those patients' needs. We know that in those two models, quality metrics went up. The time it took to provide this excellent care went down. Patient satisfaction, the team satisfaction, physician satisfaction went up. Revenue increased. And in this module, I'll show you, you can see some of those metrics to make the return on investment case, which is our next step. This, another example is a group out in Intermountain Healthcare who shared that they have 2.5 MAs to every clinician. Again, so that the clinician can focus and dedicate uninterrupted attention to the patient. We have our own agenda. We know what we need to do for that patient, whether it's colonoscopy, a mammogram, a vaccine, a blood test. But we need time to have the patient tell us what their concerns are, which may not be on our agenda. This frees up time to find that out as well. We may be thinking about all these other things to keep them healthy and be preventive, but the patient may have a concern about not being able to sleep, or their husband's memory's not what it used to be, or they fell yesterday and or they're short of breath. So having time to develop that differential diagnosis and hear what the patient's concerns are, not just what we need to get through each day. And that's at Intermountain Healthcare. Their experience with this model, once again, access was able to go up by 20%. The time it took went down and revenue went up. More importantly, in all three of those examples that I gave you, the work was done at the end of the day. The doctors, the clinicians were not taking 2 hours of documentation work home. Without this expanded care model, which relies so heavily on the medical assistant, a physician has a choice. We can either give our undivided attention to the patient, build trust, and take the documentation home, because we can't take the patient home, something's got to give. And so we are sacrificing much of our time at home to be with our families and exercise, take care of ourselves. And it's also a patient safety issue. If you're doing documentation at home, trying to remember what happened in the morning, the chance of an error occurring is so much greater. The last example I'll use is referred to is at University of Utah in Redstone. Here with in-person MA documentation support, quality went up, the cancer, diabetes, immunizations went up, productivity went up, and the cost easily paid for itself, and patients were much happier, Work was done at we said at lights out, and no work brought home. The third step in recruiting and retaining MAs is to make the business case so you can pay for it. So, and you can give them the salary that will keep them working on your team. And showing the return on investment is very important here. There's an article referenced in the Steps Forward Toolkit, sharing the net revenue, the direct cost, the operating profit, and the increased encounters per day. I'll share with you later that in Cleveland Clinic, in order to pay for the second MA, they saw that they would need to, they planned that they would need to see 2 additional patients a day. In fact, they were able to increase to 7 or 8 patients a day, giving better care with and taking less documentation home and having fun. The Steps Forward Toolkit also has a calculator, so you can make the return on investment case. You can put in your practice and how much you pay your physician per minute, the cost of staff time per minute, how many clinic days, punch it all in for your particular practice. And if an hour is saved a day, which was more, in my experience, more than 2 hours a day saved doing team-based care, you could save, if 1 hour a day, $26,000, 2 hours a day, $52,000, clearly paying for itself and meeting the needs of more patients. The fourth step is, once you have hired your MA, be sure that MA has good training on board. In the toolkit, we have shared by Dr. Jerzak at Bellin, a list of onboarding tasks going from week 1 all the way to week 12. So 3 months of onboarding. I'll also share, Dr. Corey Lyon at University of Colorado shared that not everybody who becomes an MA has the same skill set. And so having an opportunity to identify who is interested and capable of doing a little bit more in the team-based care type of role is helpful. So they do a 1 week of onboarding. At the end of a week, they ask the new hires to take a typing test and do some clinical documentation of a simple clinical vignette. If they pass that test, they are then offered the MA to continue with additional onboarding and offer them an opportunity to become part of the expanded team-based care. If the interest of the MA is not as great, or they're not as good a typist and unable to do that, and they're more comfortable rooming the patient and taking some simple vitals, then that is the route they would take. So onboarding can be similar in some ways, but it also can divide depending on the skill set, so that the MA's skills are maximized and that everybody's working at the top of their skill set. Because as you heard from step 1, the pathway to becoming an MA is very different. It could be an apprenticeship model, it could be 9 months of training, it could be 2 years of training. So everybody that finishes or becomes certified as a medical assistant may have a different set of skill sets. And the fifth and last step is, how do you retain that top talent? We know that physicians are reluctant to delegate tasks unless they know and become comfortable with the people on their team. That's true for everybody. But if the MA is rotating all the time, there isn't that relationship building so that everybody can trust each other, because we don't know each other's skill set. It's important to retain top talent for the physician, but it's also very important to recognize that the medical assistant wants to see a path forward. If I'm learning and I enjoy this work, how can I grow? So be sure that you're including some professional development. And there's a current module on Steps Forward called Medical Assistant Professional Development, with tools to help you continue to provide your medical assistant educational programming throughout their work here at your organization. There are a variety of professional advancement plans because throughout the country, we recognize the importance of some growth. We call that a ladder. So I like to think of the role being in three different parts: room and run, an expanded role where you do a little bit more than that, and then advanced team-based care. Basic, intermediate, and advanced. The return on investment for hiring that MA also increases as you go along that spectrum. In the module, we give you several examples. I've mentioned a few at Bellin, Cleveland Clinic, Rush Medical Center, and University of Colorado. Some people have made it a ladder, MA1, 2, or 3, or an MA1, MA2, and a lead MA who might have other MAs reporting to them. So everybody is looking at an opportunity so that they have professional growth. We also know that this is an equity issue. Many of our medical assistants are hired locally in our local communities, and they reflect our local communities. And it's important that our patients who come from our communities see that the staff looks like and talks like they do, right? So that they develop a trusting relationship with the medical assistant on the team as well. I'm going to finish talking about what this might look like. I will share with you from Cleveland Clinic that Dr. Kevin Hopkins, also one of our physician advisors at the American Medical Association, developed this new model with 2 MAs to every 1 MD. Revenue went up 30%. It was much more rewarding to spend time with patients, is what we were called to do. They have an MA doing in-room support. The MAs love it because they get to know the patients. They get to see what the doctor's thinking, what the patient's concerns are, and they feel much more empowered and more connected to the community and their patients as well. So what might that look like this afternoon for you? So this is a typical appointment. This would be a patient that I would have with numerous medical problems. So imagine a woman with diabetes, depression, obesity, hypertension, and asthma. You're already half an hour behind schedule. You opened up your EHR and you were blasted with quality metrics that are all red. You're being told your immunization rates aren't what they should be. Your blood pressures aren't what they should be. Your A1Cs are too high. And she's on a list of medicines and you've only got 20 minutes. With no previous planning, nobody to assist you in this work, you can literally only put out a few fires. You could refill her medicines, encourage her to lose some weight, ask her if she's getting any exercise, but that's about it. You put your hand on the doorknob to leave, thinking that you've done what you needed to do. And as you leave, she says, well, do I need a mammogram? And I need a handicap parking sticker. I need an eye referral. I can't sleep anymore. My knees hurt and I can't afford my spacer. Now you're about 50 minutes behind and your next patient probably has a similar set of problems. And this may be the healthiest patient you see that day. She doesn't have a new complaint. This is managing chronic disease. So you feel frustrated. You know you're not meeting that patient's needs and you're already an hour behind. The staff is frazzled. Phone calls are coming in. People are interrupting you to get to answer a phone or to order a mammogram because the patient's waiting. And it's just not sustainable. This isn't going to work. We're not going to get our patients healthy if we do it this way. And between this visit and for this example of a patient, Mrs. Hughes, what happens between this visit and 3 months from now? She's probably going to call to find out the results of the lab work that you ordered today, and you're going to have to adjust medicines depending on that lab work. So there'll be numerous phone calls. She'll need an order for some other, to meet another healthcare gap. And she also needs immunizations that you failed to notice. If you add up all those concerns, needs over the next 3 months, it can equal about an hour a day. I mean, an hour between those 3 months. So for one patient, all those touch points, and she's calling, you're trying to call her, you're sending in enough refill because the thyroid test came back and you need to adjust the medicine. A1C is too high, you need to adjust that medicine. You don't know if she's really taking her medicine. All these fragmented interruptions between now and her next visit are unplanned and interrupt the workflow of another full day of patients. And it can take an hour. Now, one patient between each visit, that's 3 hours unplanned, unreimbursed work in a year. What if we took that time and did pre-visit planning, pre-visit labs, and had everything you needed so you could take care of that patient that day? And that's what we're talking about here. With practice re-engineering, you could save 3 to 5 hours a day. And with expanded team-based care, an integral part of that is your medical assistant with 2, or as you saw, 2.5 MAs for every 1 physician. You can save 3 to 5 hours a day. What might that look like? Well, when this patient returns with team-based care, you have the labs you need. Protocols are sending her to her diabetes education classes. You have time to recognize that she was not taking some of her diabetes medicines. You have time to read, so we can work on medication adherence. You can look at her long list of medications and get her off some medications that might have been promoting weight gain or leading to fatigue. So tapering those off, she can be on less medicines, closer to goal. Between now and a visit from now, no more phone calls. And that's because your medical assistants are a valuable part of the team. So we need really to move away from the lone wolf model. Here I am during COVID, alone in the office, trying to do a million tasks, those 1,600 guidelines. I'm ignoring my patient, and we're all wearing masks. It's so important to be close to the patient. Or we can move to a newer model where the medical assistant is absolutely key. Here you see the medical assistant in the room, and I am having undivided attention, having a conversation with my patient in the room. So steps forward is open access. You don't need to be a member. You don't need to be in healthcare. You don't need to be a physician. There's over 60 toolkits that you can use this afternoon to implement some of the things that I mentioned here. I encourage you to look at those. And the AMA has a tremendous number of opportunities to improve your efficiency so that you can get back to taking care of patients, which is what we have all been called to do. Here's just a few of the modules that are there, teaching you how to implement team documentation, do pre-visit labs. One that's of great interest now is adult vaccinations and how to do it with a team-based approach, how to have time to address vaccine hesitancy, especially in the time of COVID. There are several modules on technology, telemedicine, physician burnout and well-being, how to implement PDSA or lean, efficient approaches, and a variety, over 200 success stories. These success stories are bright spots where things worked well. And fortunately, people are generous in sharing those great cases. And I hope some of you today will take what we've talked about and then share those success stories with us so we can publish them on this website. And I will end with just a few pearls. The take-home points that medical assistants are a critical part of the team, that there are a variety of ways to become a medical assistant, and only when the whole team works well together can we meet the needs of the patient, which is the ultimate goal. So I'll end there, and thank you for your attention.
Thank you, Dr. Brown. After these next few slides, we will transition over to the Q&A. I know Dr. Brown already mentioned the Steps Forward platform as a resource, but I wanted to mention that the Steps Forward toolkit associated to this presentation will be published to the platform in the coming months. A communication will be sent out to all of you as soon as it is published. But for additional resources, in addition to the Steps Forward platform, please visit the American Medical Association website. Again, we really appreciate you joining us today and hope that you're able to join our next upcoming webinar, which is scheduled for Tuesday, March 2nd at 1 p.m. Central Time, which will feature Dr. Elizabeth Harry, who will speak on cognitive workload, a modifiable contributor to physician burnout. And then for any general questions or comments, please feel free to email the Action Labs inbox at action.labs@ama-assn.org. Okay, thank you. Again, Dr. Brown, we already have several questions in the queue, so we can just go ahead and jump into the Q&A if that's all right with you.
Sure.
Wonderful. So the first question that we have in the queue asks, it states that there seems like a few different ways to become an MA. And this participant asks if you could review the most common two.
Sure. Thanks, Brittany. And thanks again for joining us this afternoon. The two most common ways to become an MA are the apprenticeship model and attending a formal course. One needs a high school degree to enter an MA program. They can range from 9 months to 2 years. Some are part-time, some are full-time. And your junior college probably has similar programs as we have here in Chicago, the City Colleges of Chicago. And there are some standalone programs that are usually a little shorter, 9 months or 12 months. The apprenticeship model requires a high school degree or GRE and is on-the-job training. So for many physicians in the country, they train their own personnel and have been delegated and have been doing the work of phlebotomy, tasks that are part of the work of the team. If you have been doing that for 5 years, if your MA has been doing that for 5 years, and the physician who has trained them attests to that, they can qualify to sit for the exam. Now, of course, they have to pass the exam, but that was how one of my medical assistants, who I rely very, very heavily on, was able to sit for the exam. She did very, very well on it and then became formally certified, which was great for me because I had just moved from a private practice to Rush University, and Rush required that all the MAs be certified. So it was, a few months. I had to buy her the books and say, have you studied today? But she really did very, very well and was very proud of it, and has grown in that role as well. Good question.
Thanks, Dr. Brown. In that you mentioned certification programs and some local innovative programs. You also mentioned some innovative programs around the country. Could you share a few examples of those?
Sure. I mentioned the University of Colorado and Malcolm X. Another one in the city of Chicago that is 5 actual hospitals are participating in is called the Medical Assistant Pathway Program. And that is an opportunity to identify interested, qualified hospital employees or organizational employees who you probably already know. They're everybody's favorite person. They may be in transport, they may be in environmental services. They have a very high emotional IQ. They always have a smile on their face, and they clearly care. But there's no ability to grow in that role. So this is, again, also addressing equity. The 5 hospitals here in Chicago got together with Malcolm X and the healthcare program there and developed this program supported by grants. And while the person identified by their manager and self-identified is interested in the program, they keep their regular job. And with a lot of effort, the evening classes occur when they're not working. They are also promised that their externship will happen at their location where they currently work. And transportation, daycare, books, tuition is all paid for. The hope is that they will then grow finish the MA program and then be able to move and progress in their career and do something that's a little bit more challenging and put some of their wonderful communication skills and obvious caring for patients use them at a different level. So that's exciting. Now, some of these, we saw some challenges there. Some of the people who entered the program hadn't been in school for a long time. So we also provided a month where they could get back into studying and taking a few little quizzes and doing the reading back to homework. But it has been a great opportunity for many people in the city of Chicago. Some hospitals are also, or some organizations are working with their local high schools. I think I mentioned that, where you could provide some of the MA training in their senior year of high school, and it would qualify, and they'd get credit for it to shorten that 2-year program to closer to 1 year or even shorter. So there's opportunities out there, and I hope I've sparked a little interest in finding some of your own solutions in wherever you are in this country.
Yeah, absolutely. We talked a lot about professional development and growth opportunities. Do you think that there are other strategies that we can be doing to enhance job satisfaction for medical assistants?
Yes, certainly feeling part of the team for everybody. And so the physician at each meeting, perhaps asking the MAs or your team meetings, first of all, hearing what their concerns are and having an opportunity to say, is there something that we're doing that you'd like to know more about? You know, how does immunization work? Or tell me, how do you pick which drug to use for diabetes? What's the rationale? And provide a safe place for the medical assistant to be able to ask a question. And then the physician providing some of that information is very helpful. Making sure that the medical assistant also reads the wonderful patient education program literature that we have is a good, very basic place. I often tell my medical students to start there as well. So I think just in making sure that there's open communication so you can build trust, because the skill sets are uneven, and having the same MA most of the time is of key importance. The other interesting thing that we did at Rush was before COVID, the MAs all got together or split in half because we couldn't close down all the clinics, but they'd get together once a month and do some self-teaching, share some things. They chose their own leaders. And once a month, they chose a charity that they all wanted to contribute to. And if they put in a little bit of money, then the last Friday of each month, they got to wear that t-shirt, whether it was a pink t-shirt for breast cancer awareness or rainbow or whatever they chose. So developing their own community is very helpful as well.
Thank you, Dr. Brown. In that response, you mentioned team a lot, making them feel like they are part of the team. And, you know, with this professional development, hopefully have them participate more in team-based care. So I want to play off of that a little bit more. Where can our audience find more information about team-based care and the MA role specifically?
Well, the best place that I have found is really Steps Forward toolkits. And that, again, stepsforward.org. Completely open access, like a government website. In fact, I was just asked by the university here, they're going to begin using many of the core modules in Steps Forward as their core curriculum for onboarding. And we encourage that. You don't need any permissions from us. We always appreciate it if you tell us what you're doing so that we can highlight it. But the tools are there, often written by MAs, like Christina Zaga, who's the head of the MA program, as well as nurses and physicians from around the country who work closely and train MAs.
Thank you. You mentioned a lot of resources there, so I want to reiterate the fact that all of the resources that we mentioned today will be sent to all of our participants. So you will have access to those after the event. I'm going to switch the topic a little bit, Dr. Brown, and move on to the element of trust. I feel like we have several questions in the Q&A that hit on the topic of trust. Trust in any relationship is important. And this next question specifically asks, how can you develop trust in the relationship between a medical assistant and a physician? You know, perhaps the doctor doesn't feel comfortable delegating tasks to the new MA. Maybe they don't feel, you know, they don't have that element of trust fully established. So how can you really improve that and work on that?
Great question. And unless you develop trust, you're not going to, nor should you, right? If you don't want to delegate tasks if you aren't 100% sure that that person you're delegating it to is capable of doing it. And as a patient said to me, how do you develop trust? Time. It really takes time getting to know each other, iterative task delegation, make sure that the person can complete that before you add another task to them. So that consistency, the same MA working with the same clinician or physician is absolutely key. And having an open dialogue. If the MA is not comfortable or doesn't understand or is fearful they'll make a mistake, there needs to be trust both ways, that they can say, I don't understand, or I'm not comfortable doing this. The response from the physician should be, oh, I'm so glad you said that. You know, I shouldn't have asked you to do that. You know, put it back on you, so that they have to trust you, because it's a patient safety issue, right? And we also need, as I hope we did with this 45 minutes we've spent together, understand what the MA educational program was. Did they go to a 9-month program? Did they do an apprenticeship model? Did they go to a 2-year program full time? It's very important for us to take the time to learn what they know and what they don't know, and what they want to know. So taking, you know, have a cup of coffee, do that team huddle, what's going on. Many of our MAs have a lot of responsibility at home. And actually when we leave, we go home, but they may be going to their second job or picking up their children from daycare, which is important why they need to get out on time, or it's going to cost them an extra $10 if they're late picking up their child. And the hourly salary for an MA is not what we wish it could be. So, you know, just how do you develop trust amongst anybody? Same way you'd have to develop trust with your entire team.
Yeah. Thank you, Dr. Brown. You just mentioned salaries, so I sort of want to shift the topic again to a bit of the retention topic. You mentioned in your presentation that retaining top talent and growth are both very important in terms of providing professional satisfaction and advancement for medical assistants. So are there other ways that that we can be providing that professional satisfaction in order to continue to promote growth and retention?
Well, it's a challenge, especially in the time of COVID. Resources are limited, but many medical assistants went into this field also because they felt a calling. They love taking care of patients. And the increased satisfaction that medical assistants feel when they are truly part of the team and they're in the room with you, so that they can understand what you're telling the patient, they're learning as well. But we also, if they grow out of that medical assistant role, that's wonderful too. If it sparks them to go on to additional education, whether it's a physician assistant or a nursing degree or becoming a physician, that's wonderful. For many, this is the beginning of a career, and we would encourage that. But feeling part of the team, ongoing learning is, you know, everybody likes to feel appreciated And starting out your team meetings with a shout out for somebody, if a medical assistant, if a patient told you, how wonderful Veronica was, well, tell Veronica that this patient told you that on the phone or whatever, or, because they pended the order or they found that this person hadn't had a mammogram and suddenly it showed an early cancer. Well, that MA helped save this person's life, right? It's not hard to find an opportunity for a shout out and an opportunity to compliment and highlight somebody's good work, and say that you helped save a life. Right?
Thank you. So in addition to these strategies, do you have any advice on how we can work on increasing the salaries of MA? This participant indicated that it's obviously quite difficult to retain MAs when they are hardly paid a minimum wage yet need to go through training. How do we even recruit other healthcare workers when becoming an MA hardly increases their financial sustainability?
And you're not alone. I think that everybody around the country is struggling with that same problem. I hope I've shared opportunities to make the business case, that access increases, that patient satisfaction increases. And there is a game changer. As of 2019, reaching those goals, as I started the conversation, organizations are leaving tens of thousands of dollars on the table if they don't reach their A1C and their blood pressure goals. Well, unless you do team-based approach, we're never going to reach those goals. So knowing that, and that has nothing to do with the ACA, that's CMS. So that's a game changer in my mind. So that's happened since 2019. Find out where your organization is there, and that's where it's coming from, that there's also providers, health insurance companies are doing the same thing. So that money could go to increasing your MA salaries or your staffing numbers. So that's, two, you increase access, and because of MIPS and MACRA, there is money that could pay for that increased staff and to increase the salary. Because you're right, it is in some places it's barely a living wage, and they're a really valuable part of the team.
Thank you, Dr. Brown. So in your response, you discussed resources and staffing. So I want to jump to this next question. This participant indicates a ratio of 2 MAs to 1 physician seems ideal. How can I make the business case to be sure that we have that resource?
Well, I think if you look at the references, especially the one from, I think I showed 4 examples and what their experience was. And in the chart, it shows the how the income increased. What I would say is that many organizations say, they put the cart before the horse. They say, well, we'll give you an MA if you see 2 more patients a day. And most physicians and clinicians are drowning and they just say, I can't. I'm already taking 2 hours of work home. I couldn't possibly. So it really is a shift to fix the chaos first. And you may find that you don't need 2 MAs, or if you get rid of the chaos and you get rid of phone calls for refills by just changing your refills from every 6 months to every 12 months. When I did that, I found an hour in my day. So you may find that your staff is more than adequate if you get rid of some of the incredible inefficiencies that we have solutions for those in some of the other toolkits. So it isn't just throw another staff. If you throw extra staff and you're still doing everything inefficiently, your overhead goes up and your outcomes don't change. So there's a lot to all of this, and I hopefully the workflow, the pre-visit planning, the expanded rooming and discharge to make the most of the staff you have is where you want to start first.
Thank you. I want to be conscious of the time. We're already at the top of the hour here, so I think that will conclude our Q&A for today. I want to mention that any questions that have gone unanswered, or if any of our participants have follow-up questions, please direct them to the Action Labs inbox. We'd be happy to follow up with you following the event. Dr. Brown, thank you so much again for your time and expertise today. To our participants, thank you for joining us. We hope to see you all again soon.